Hello everyone, I'm Rachael Lowe from Physiopedia and today I'm chatting to Chris Littlewood. Hello Chris, thank you for joining me today.
Hi Rachel, thanks for having me.
I'm looking forward to talking to you all about the shoulder, exploring your knowledge and trying to share that with everyone else out there today. Perhaps, as usual, we could start with you giving a little explanation of or just introducing yourself and what you get up to for work.
Okay, so I'm a physiotherapist by background, by training, and I now work as a senior lecturer in clinical trials at Keele University in the UK. So that means that on a daily basis I'm designing, conducting trials, trying to help us understand a little bit more about what works, what doesn't work, and sometimes the reasons behind that.
But your trials, what mainly in shoulder pain, is that correct?
Yeah, historically that's starting to change, but yeah, that's where most of my experience has been, and that's where my PhD was. So yeah.
Okay, so I wanted to talk to you about shoulder pain today. Perhaps later on we can talk about the other things that you are getting up to and have coming up. Trying to share some of your knowledge with some of the people that might be watching or listening out there today. Can I start by asking you, how do we classify shoulder pain and the different types of shoulder pain, and what sort of, there's not really a consensus on classification systems or any subgrouping or anything. If we need to do that, what are your thoughts on that?
Well, we classify with difficulty and with imperfect knowledge. And I think by rounding off your question, you also answered it. Because, we were all schooled, we were taught about things such as a rotator cuff disorder, frozen shoulder, an osteoarthritic shoulder, an unstable shoulder. We use terms such as rotator cuff tear, labral tear, all those pathoanatomic kinds of diagnoses, which I still think are the most prevalent. I think that's what most people still seem to use. But what we do know is that those diagnoses don't seem to explain the pain that our patients complain of, really. The diagnoses don't necessarily inform the treatment that we should offer. I mean, the good example is rotator cuff tear. So you identify a tear, great, but we also know that people have rotator cuff tears and don't have any shoulder pain. So a rotator cuff tear doesn't infer the need for an operation, although the diagnosis might suggest that. Essentially what we've got to do is wait and see, or we've got to try some physiotherapy. If those things fail, then we might consider an operation or not. So it's still very much a stepped approach. So the diagnosis in that context isn't useful, and it has no prognostic value either, because some people with rotator cuff tears get better, some patients don't. But that mode of thinking still seems to predominate. Of course, there are other approaches, predominantly within physiotherapy, I think, what I call these rehabilitation classification systems. So in the shoulder, perhaps the most commonly used ones are Jeremy Lewis's shoulder symptom modification procedure, and also Mackenzie's method, mechanical diagnosis and therapy. But those approaches just rely on symptom response, make no assumption about the underlying structural pathology. So they sidestep all the structural issues. But I think those approaches are still very much in their infancy. We don't know whether they do offer added value over usual practice at the moment, but there is some promise because they sidestep some of the current issues. But there's certainly a lot more that we need to know. And then, of course, there's another approach, which is guiding treatment by prognosis rather than diagnosis. And I'm just involved at Keele with a fantastic new study that's looking to identify prognostic subgroups that might appropriately direct treatment or not. But we're a few years away from getting that answer, which is unfortunate.
Yeah.
But I think you ask a really important question. One of the points in your question was, does it matter? And I'm a little bit concerned that the diagnostic subcategories that we use at the moment might not matter. I mean, there's some early evidence to say that if you've got a stiff shoulder, then you might treat that differently to a non-stiff shoulder. So, for example, if someone can't rotate their arm, those patients you might treat differently. They might have a different prognosis. But it's shocking. Do you know that there are over 400 trials in shoulder pain? And it's desperate to say we still seem to know so little. And the ideas that we have at the moment, I think, are likely to change dramatically over the next few years as we start to see bigger and better studies that can offer us more definitive answers and that are designed in a more robust way. Yeah, it's that was a long-winded answer to say. I don't know, to be honest.
No, I think that's a good answer and good explanations, and it's an interesting conversation to have. And you mentioned there's a lot that we don't know, but there are some things that we do know. So currently, what do we know about the shoulder?
Without preparation, what do we know? Okay, so we know for a significant number of people that it's not a short-lasting problem. It isn't self-limiting, and for a good number of people, they can expect to complain of shoulder pain for a number of months, perhaps longer.
Yeah.
So, and I think it's really interesting. 6 months after the onset of a new episode of shoulder pain, 50% of people, so 1 in 2 people, 6 months after the onset, they're still complaining of shoulder problems. By 12 months, that only goes down to 40%, and that remains the same to 2 years. So the idea that shoulder pain is short-lasting, self-limiting isn't the case, so we understand that. We also understand that those people that do recover, recurrence is common as well. So I guess we know that, which is useful, because that can help us begin to frame our management almost, that this is likely to be a longer term problem. Let's almost challenge our short term thinking and look to wider horizons. But then I guess more recently, what we do know is that this term subacromial impingement, I mean, it's the most commonly used term in the shoulder, and it's certainly something that when I was training, it was something I was taught, that this type of shoulder pain was due to a bone spur that was compressing the rotator cuff. So when someone elevated their arm to the side, this bone spur or this extra tissue was compressing the rotator cuff. So we understood, or we thought, this was a compressive or an abrasive pathology. And we've seen the recent Seesaw, the Can Shoulder Arthroscopy work publication in the Lancet, which showed no difference between surgical procedure to remove the bone spur and a procedure where the bone spur wasn't removed. Patients got better. So the idea that, and this is in the context of other literature as well, so the idea that subacromial impingement explains this pain is challenged, which is, I think, a useful thing to know, because with a physio I think he's based in Yorkshire, he roams everywhere, but Andrew Cuff, who's a physio, he led a really great qualitative interview study recently that looked at how patients understood their shoulder pain when they had this diagnosis of impingement. So they were interviewed by Andrew once they'd been seen in the orthopaedic department, and these patients quite well were saying, well, my problem is due to this bone spur. It's compressing my rotator cuff. So when I move my arm, this spur is compressing or tearing. That's why I've got the problem. But then the next logical thing they said was, so why am I here in physio? If my problem is this bone spur that's causing this problem, with all the greatest respect to you, I don't think physiotherapy can change that. And of course we can't. And then sometimes when patients talked about their problem with a rotator cuff tear, again, if my problem is due to a cuff tear, why am I coming to you? Because I don't think you can repair that cuff tear. The language and the way the patients are understanding this problem has a huge impact, because you can see straight away, can't you? That's a barrier to physiotherapy. But what do we know? Well, people get better even with the bone spur. People get better with the rotator cuff tear. But on the flip side as well, sometimes we see scans of patients and they don't have any obvious structural pathology. They don't get better. So it's a real challenge. So we know that shoulder pain is not short-lasting, it's not self-limiting for a lot, and we know that subacromial impingement is unhelpful, potentially harmful. And I guess the other thing we know is that there's a whole range of different approaches, within physiotherapy, within surgery and other professions, a whole range of different approaches, and there doesn't seem to be a signal of one superior approach at the moment. And our real big concern is that perhaps our interventions are working, I use that term loosely, but patients are changing over time because of placebo or simply the passage of time. And as physios, we've been patting ourselves on the back over recent years, because we've seen some trials that say that physiotherapy is at least comparable to surgery in terms of clinical outcomes. In the short term, the mid-term and the long term, we all think, great. But then the Seesaw trial essentially was suggesting that the effect of surgery was due to placebo or natural history. And so if surgery is due to natural history or placebo, and physiotherapy is the same as surgery, well, what's to suggest that perhaps physiotherapy, the response to physiotherapy is not placebo and natural history? And we need to be really mindful of that. I know the cheaper option, which goes for us at the moment, but where, a course of physiotherapy in the UK costs less than £200, but a subacromial decompression costs at least £1,500. So we're much cheaper than an operation, but we need to be really mindful that perhaps a lot of our effects are due to placebo and just the passage of time. And that needs to be a real stimulus for us to think out of the box, I think.
So there's a couple of things there that we could talk about. This thing of the placebo topic we'll come back to perhaps, because I just want to go back to the subacromial impingement conversation. So if we aren't impinging, if there is no, if the bone spur isn't the problem, then what are we seeing in the shoulder that's causing the problems?
Oh, I don't know.
Okay.
And I've tried to look at this. So I used to think it was I used to think that this pain problem was because of soft tissue degeneration, what we used to call tendinosis.
Yeah.
And my view was that you'd apply an exercise program and that tendinosis would remodel, and that's why the patient would improve. But we did a systematic review, me and some colleagues, and it just didn't support that. Patients said, I'm getting better, so less pain, improved function. But the structural pathology that we could observe on the scans wasn't changing. So that was a real challenge.
So are you talking about like tendinopathies here?
Yeah. So I think that's why the terminology changed as well. So we all used to remember using the term tendinitis?
Yeah.
And then we started using the term tendinosis.
Yeah.
And then we started using the term tendinopathy. Think about the term tendinopathy. What does it mean? Tendon pain of unknown origin.
Yeah.
So it's not, you can challenge the concept of tendon pain. We're starting to ask some real searching questions about pain. I think there's lots more to understand. But tendinopathy potentially isn't a helpful term either. Or perhaps it is because it reflects the uncertainty. So the tendon changes don't seem to explain the pain, or at least in the way we use scans at the moment. We've often thought that patients get stronger in response to exercise. But again, from the studies that I've looked at, patients get better over time, but strength stays quite similar. So the idea that an improvement in strength explains why they get better isn't the case. And also there's a body of evidence that looks at the scapula, the way the scapula moves. And again, patients report improvement over time, but the position or movement of the scapula doesn't change. So the idea that faulty biomechanics fully explain pain, again, I think is really open to debate. So I honestly don't know. I mean, I often talk about Louis Gifford's mature organism model, which really helped me to rethink pain in a broader way, rather than the old Cartesian way of nociception equals pain, which again, we were all taught. If you were one of the clever ones at university, you'd often use the term nociception and pain interchangeably. And of course that was wrong, but that was our understanding at the time. But I think Louis Gifford's mature organism model and this idea that we have a scrutiny process for this whole range of different inputs. So, for example, the input I've got, that, you know, you looking at it from a computer screen, the temperature in the room, the light, the fact that I'm sitting on a hard chair. We're processing all these inputs at any one time, and we're scrutinizing, and that results in some kind of input based upon, you know, knowledge, beliefs, past experience, all that kind of thing. So I do wonder, you know, does Louis' model help us to explain why some of our patients change or why they don't? But I certainly think what it does do is it gives us a broader appreciation of pain, which in the shoulder, it just isn't apparent at the moment. You know, we seem quite confident with the notion of a biopsychosocial approach in the spine. But then you move 15 centimeters to the side, to the shoulder, and we're back to biomedical and structure predominantly. And I know that's not the case for everybody, but it seems to be very much structurally driven. We're all about testing. You know, scans, for example, the amount of ultrasound scans done for the shoulder now is just, it's incredible. And I think it's driven by biomedical thinking that, you know, this observing this structure can explain the pain that our patients complain of. And I don't share that optimism at all.
Okay, so listening to you
that
talk,
was a very telling okay.
Well, I'm going to ask you another question now, and you're going to shrug, because we haven't prepared these questions. This is an informal conversation, and so you're talking about that we don't know the cause of shoulder pain, we don't know what's going on, we don't know why people are getting better, and it may simply be placebo. What's a clinician supposed to take away from that to be able to approach an individual that comes to them with shoulder pain in the clinic? What's your sort of advice and that you have for clinicians there?
Yeah. So the first rule is do no harm. That's the absolute first thing. And going back to our question about what we know, so let's stop using terms such as impingement. So that will be a first guidance. Stop breeding fear avoidance in patients. So the idea that there is one perfect way to move and we need to return people to that perfect way before they can resume function. So we can challenge some of those harmful effects. But this is almost the chasm that I find myself in. And this, so when we talk about this group of people that complain of shoulder pain, where they can still move their arm, but it hurts them to move their arm. You know, so some people might call that rotator cuff related shoulder pain. Some people might call it subacromial impingement. Some people might call it a shoulder strain, etc., etc. But for that group of people, I still tend to use the term rotator cuff tendinopathy, because it almost sits in that chasm that if I'm certain about structural diagnosis, I don't think that's a valid approach, and potentially it's a harmful approach if we give a signal that someone has a cuff tear, for example, knowing that a good number of patients, about 80% of people with a cuff tear, improve without needing an operation. And then we go to the other side. If we express complete uncertainty, we risk the patient losing confidence in us and just going elsewhere. So I almost think there's a halfway house where we as clinicians and researchers have to deal with that uncertainty. And part of that is using terms that might not fully reflect the truth, but at least aren't harmful. So that's why, you know, for example, rotator cuff tendinopathy, it seems to reflect this group of people. You know, it makes sense that there's a problem with the muscle and tendon. It's lacking fitness, it's lacking capacity, it's lacking strength. And that doesn't reflect the complexity of the presentation. But what it does, it gives us a foundation on which we can prescribe an exercise program, which seems to be at least one of the best ways to treat these patients at the moment, with all the caveats. So our job is to be the filter of that uncertainty. And I think with some patients, especially when you develop a relationship, you can express this uncertainty quite clearly. And I know other clinicians can express uncertainty much better than I can. But I think I've just developed my own halfway house to reflect my limitations and, you know, what I know, what I don't know, and my communication skills, just with that ultimate rule of just do no harm. And I remember years and years ago, I've been really fortunate through my career to have some really important mentors at really important times. And it was about, 15 years ago now. I was about to say 10 years ago. Time flies. It was about 15 years ago. I was working with Julie Shepherd, who's a physiotherapist in Cheltenham, and she would, and I tend to use certain terms with patients back then, such as a disc derangement and a facet joint. And Julie would always say to me at the time, okay, you've used that term now, but what are the future implications of using that diagnosis? So you've said someone's just got a bit of stiffness in the joint. What happens when they don't get better? Clearly, it's not just a bit of stiffness in the joint, and that introduces uncertainty to the patient. This idea that the disc explains back pain, we've challenged that completely now. But once you've given someone that label, it really has an impact, doesn't it, for the future journey? And a few years after meeting Julie and listening to her at length, I started working as an ESP. And so I was starting to receive those people further down the line, and I recognized the impact of language and the certainty of language that previous people had used that had really, I guess, hampered or even harmed patients, and just challenged that journey, really. So ultimately, do no harm. If you can reflect uncertainty, do. And this is one of the beautiful things about the Seesaw trial. Can you imagine this discussion? Okay, you've got a problem with your shoulder, and it hasn't responded. You're still not happy with where you are. We've done a thorough examination, so we can reassure you there's nothing serious, nothing life-threatening here. Okay, that's the first thing. But what this examination also tells us is that there isn't one definitive treatment that we can offer you. We've got options. We can offer you an operation, and that operation is at least as good as anything else we've got at the moment. But it has cost implications, and of course that varies across the world and within regions. So we can offer you an operation. It comes at a cost, and it has risks. But the effects of the operation are likely to be due to placebo or just the passage of time. But that's something we can offer you. And you can imagine talking about this hierarchical intervention, saying it's likely that it works because of placebo and the passage of time. That will be quite powerful. Or if you're not happy with an operation, we can offer you physiotherapy. Similarly, the results might be due to placebo. They might be due to the passage of time. You might benefit from the support of seeing a physio, the regular contact, helping you get through this. And you might also feel better about yourself because you'll be doing something active to address this problem. Or we can wait and see. By all means, come back to see us in 3 months. Let's have a chat about your progress, see how things are changing or otherwise. But we feel reassured that you might do just as well, just by going ahead and just see how things go. And that's a fantastic discussion to have. It gives the options to the patient. And I don't know whether you've reflected on this. Why do people become patients? And often I think, and I don't mean that to sound derogatory if it does, but I'm trying to highlight the transition from someone not seeking healthcare to someone seeking healthcare. And often it's because of the unknown. They're anxious. What does this pain mean now? What's causing it? And what will happen in the future? And if you can have that discussion by saying, okay, we're reassured from the examination, it's likely to improve over time. It might be slow. You're probably looking at 6 or 12 months. But if you can wait and just see how things change, it's likely to be as good as the other options that we have. If it isn't, we've always got these other options. And I think that might be quite powerful to patients, to give them that choice. But I certainly reflected back, and when I used to talk to people and say, okay, I don't think further physiotherapy will potentially help you, by all means, I can refer you on to a surgeon to get their opinion. And the number of patients that say, I don't want an operation. I don't want to go anywhere near an operation. And they volunteer themselves. I'll just see how things go. It's interesting, isn't it? It's interesting.
It is really interesting. And a lot of what you're talking about is from a physiotherapy perspective, is just the intervention of the skill, our communication and education skills that we have in just supporting, and you mentioned it already, in supporting the patient through the process, and whether that's not just placebo, but that is an intervention in itself.
Yeah.
And you've kind of talked about that with all that you've said so far, but you have also implied that we would give activity or exercises for a patient to do. So what kind of interventions in that domain do you think are effective in the shoulder region for these people?
Yeah, so I've done quite a lot of work on this and a lot of thought. So looked at what other people have done and also tried to evaluate some approaches myself. I think it seems fair to say that many of the trials that have been done have important limitations. So often that means that we can't be confident in their results. And also when you look at the trials, there doesn't seem to be one clear superior type of exercise. So, you know, in the UK, for example, scapular stabilization exercises are really popular, and probably the most common intervention for people with, you know, that movement-related shoulder pain. But you look at the evidence for that, and it's really open to question. So over time, my approach evolved through clinical practice and then research to say, well, let's try and do the minimal number of exercises. Okay, but by all means, you can prescribe 4 to 6 exercises, but what's the point if one will do the same? And it kind of makes sense in a scary way that perhaps one exercise is comparable to 4 exercises because it's a placebo or natural history response, which is a little bit frightening. But we have seen a bit of a dose response. So those patients that actually seem to do their exercise do seem to do better. So if you're doing more exercise because you're prescribing more, that might be helpful. But what we can't assume is just because someone's more adherent to their exercise, that's why they got better. Because think about the drivers of adherence. And one driver of adherence is you're confident in the physiotherapist, for example. You're confident in the prescription, which might enhance self-efficacy, which might drop anxiety levels. So there's a whole range of other factors to consider. So I think, you know, prescribing the minimal number of exercises, I think it's helpful to prescribe exercise in relation to their functional problem. So you're challenging their functional problem. If a person has a problem doing serving at tennis, for example, or lifting a bag, then ideally the exercise should establish an acceptable baseline and then progressively increase tolerance in relation to that functional movement. Give them time, and again, whether that be due to natural history or the response to exercise, patients need that information right at the start. But what I found in a couple of previous trials that I did, in the first one, we didn't give any information about prognosis. So after 2 or 3 weeks, patients were losing motivation because they weren't, you know, exercise, if you are going to get a response from exercise, it does take time. But because we hadn't had that discussion, I know, and it seems barn door obvious, but because we hadn't had that discussion with people, they started losing motivation. But then in the next trial, when we had this discussion and said, this will take a minimum of 12 weeks of regular exercise, patients were fine. In fact, one patient reflected back to me and she said, why would I expect this to get better quickly? I've had it for ages. And of course, and it just made sense, of course. But often as physios, we've got this perception we should rush things through, shouldn't we? And you know, we can get things better more quickly than what they actually will. So minimum number of exercises that are progressed over time and they're given time. Then the biggest debate that the biggest question that I get asked is this idea of should exercises be painful or not? That's the real one that I get asked a lot, and it seems to be a real challenge to people. And I was always a very strong advocate that exercise should be painful. Because I was thinking that the tissue was remodeling, so you need heavy loading, very much based on Alfredson's work. And essentially I was translating Alfredson's work from the Achilles into the shoulder. So I was a strong believer. Ben Smith, who's a physiotherapist at Derby, recently did systematic review that suggested that people, if painful exercises are prescribed, then patients tend to show better short-term improvement, which was interesting because we don't think that, do we? We think painful exercise will lead to, you know, patients getting worse. So I still think with exercise we should be challenging patients. If that's uncomfortable, I'm not worried about that, providing it's acceptable to the patient. So if exercise at whatever pain level is not acceptable to the patient, then I wouldn't prescribe that because it's worthless. It's wasting my time and the patient's time. But rather than now saying it should or it shouldn't be painful, I try to push patients as hard as we can, but at their acceptable level. Because one slight concern I have is that we undercook lots of our patients. And by that, I mean we don't help them to achieve their potential. Because over time, there's a handful of patients that we've all made worse by applying a manual therapy technique or being too vigorous. And I think we get burnt by that, and it almost creates fear avoidance within us. And that means that the other 99% of patients, we don't push them to their potential, and we accept a suboptimal level of outcome, which really by definition is harmful. If we're not helping patients to reach their potential, then that deficit is relative harm. So I think, yeah, pushing people to help them achieve their potential, not worrying so much about the pain as long as the patient isn't so worried, and try to help them think about pain in a useful way, and think back to Louis Gifford's mature organism model, that pain isn't necessarily a reflection of the state of the structure. It's much more complicated than that, and the way the patient's thinking about their problem, their past experience, that can all feed into that pain presentation, which is why when you explain things in a simple way, and then in the clinic, if you repeat the exercise with the patient, so don't just prescribe 3 sets of 10 twice a day without examining that in the clinic. Examine the response to the exercise. And what's so interesting, I've seen it time and time again. Just imagine you've got this person with a painful arc, just like an abduction, painful arc, and you get some TheraBand, for example, and you might start examining them in early range, just saying, okay, as you repeat this over 10 reps, 3 sets, what's the response? Can you cope with that? Are you happy with that? And what you find, without any prompting, just by being there and just by being encouraging, the patient starts to test themselves more, so they move more, they go further into range, and you see that, I guess, symptom response in response to loading. But not everyone gets worse when you load them up. Fear avoidance, boys, is really apparent in the shoulder. We think really differently about the shoulder compared to the lower limb, for example. No one, I don't think, would question the notion of painful exercise in Achilles tendon problems or patellar tendon problems. I don't think, maybe they would. Maybe I'm out of date with that. But you can't go anywhere and suggest that it's okay to load the shoulder up without people hands in the air, shaking their heads, and all sorts of really vigorous responses. So I'm interested to know why do we think so differently about lower limb and upper limb problems? And I do wonder whether one reason is because of the impingement model, whether that's really influenced our thinking, and what we're thinking of, when we're loading the arm is we're impinging rather than just loading a tissue that just needs to get.
So we do need to move away from this thought of impingement, and it seems like it has many implications for us as clinicians in how we talk to the patient about their problem, in how we offer them a prognosis, in how we actually provide exercises and the dose that we provide and the loading through the rehabilitation program. So that's coming out of that. I'm hearing that from your conversation of what you're saying. Yeah, but you are advocating that we should give exercise.
Yeah, but there's a caveat to that, I think. Yeah. It's a caveat that we don't know why it works or why it doesn't work. And we need to be mindful that it might be due to these placebo natural history responses. But based upon the whole range of different approaches that different people have taken, I still don't think we know what the optimal parameters of exercise are. So I'm an advocate of joining up thinking a little bit between people who have done these kind of trials, who teach these kind of things. Join up thinking, try to really test what are the important prescription parameters. And then at a time point in the future when we feel like we've at least got a framework around what's important in terms of type of exercise, number of repetitions, should it be painful or not, how long do they need to exercise for. Once we've got some greater, not consensus, but just more joined up thinking, when we're confident this is the best kind of exercise program we can deliver, that would be the time to test that program against a wait and see approach.
Yeah.
And at that time, If exercise is no better than wait and see, then we need to move on and think about these things differently.
But for now, you're not suggesting that we should turn away all shoulder pain patients, are you?
No, no. I think we should give them the choice, introduce uncertainty where we feel we're able to. Just recognise that no one or group of exercises seem to be the best option. Try to really focus on the explanation. So the explanation you give enables people to exercise, so they understand why they're exercising. And again, I go back to my point: why would logically, why would a patient who understands their problem as a rotator cuff tear, why would they exercise? Because surely exercise will only tear it further. But try to challenge ideas, and you can use research to do that, because there are lots of published research studies. Try to challenge and helpful ideas. Try to come up with your own explanation that will facilitate someone to exercise, i.e., we need to get this stronger. We need to increase the capacity of your shoulder. We need to improve fitness here. Try and use some perhaps more constructive terms, and then think about how can we now best fit an exercise program into that person's lifestyle. Because it's hard to do exercise, isn't it? I remember, again, it was a long time ago. I used to be one of those physios who would prescribe 10 exercises every hour. And you cringe when you look back, don't you? It's like, oh, but I once tried it myself. I thought, okay, I'm just going to try and do 10 cervical retractions, not hard. And I managed one set in the full day, between patients. And I thought, I've got to think differently about this. So trying to fit the exercise into a person's lifestyle, having that discussion with them, so when will you do this exercise? Support them to recognize that when they haven't done the exercise. So, for example, something simple like an exercise diary, because we all know the self-report of our behaviour. Oh, I've only had 2 glasses of wine, this week, and you look in the bin and there's 6 bottles. That kind of that's the reality of self-report. It's inherently unreliable. So to help them try and monitor their behaviour, and then as physios, perhaps shift our thinking a little bit towards supporting that behavioural change. I remember pre-PhD when I talked about the idea of evaluating a self-managed exercise programme, which didn't rely on manual therapy or electrotherapy. It was very much around a single self-managed exercise. And at the time, this would have been about 2011, one of the most common statements that I got was, "You're doing us out of a job." If we're supporting self-management, how do we pay the bills? Well, the bottom line is there are enough patients to go around, but surely we have to keep the best interests of the patient at heart. And if that is through supporting a self-management approach rather than offering what many regard as very short-term interventions, I think that's where our focus should be really.
Yeah, no.
So it's challenging skill sets, isn't it?
I think, and I think physiotherapy is evolving, our profession is evolving, and I think you've actually covered on quite a lot of the things that are influential within that progression of our profession. And I think all that you've talked about today it's really interesting, because in talking to lots of different people about the shoulder, there is a lot of consensus in things like, now there's no impinge, there's no bone spur and things like that, but there is still no consensus on the shoulder and how we classify, how we actually, there's no specific ways to treat subgroups of patients and all that sort of thing. And some of the things you've talked about have actually been very good to provide us with a way forward with those patients with shoulder pain, in all that you've talked about with how we should communicate with them, and because of our uncertainty, and how we can encourage the self-management and help them through this through the passage of time as they heal, if it is just a placebo event. So I think everything that you've said has been really useful. I'm respectful of your time today, and I don't want to keep you for too long. Is there anything else that you are working on, or any other particular knowledge that you think clinicians should be using within this group of patients?
Okay, well, just to the first part of the question, I'm really excited at the moment. We're working on a couple of studies, one looking at rehabilitation after rotator cuff repair. an area which has really been dominated by fear avoidance. You know, if we move people too quickly, it's like a cheese wire. The cuff will rupture. So we're looking to evaluate different approaches to post-operative rehabilitation, but hopefully challenging existing thinking and perhaps moving that field on, because it hasn't really changed. For many, the approach to rehab is still extremely conservative. So that's one really interesting area. The other interesting area is this area of traumatic rotator cuff tears. And people perceive traumatic rotator cuff tears as being very different to non-traumatic or degenerative cuff tears. And so I'm trying to build an argument that perhaps there's a case to do a trial of physiotherapy versus surgery. Because at the moment, the assumption is that, you know, surgery is the preferred option, and it should be done early. And I'm not convinced by that argument. So that's something that's interesting that's going forwards. But perhaps the one, just thinking about my background and my perspective, the one thing I'd really encourage people to do is just ask more questions, and perhaps don't necessarily follow people you perceive to be experts.
So ask more questions of other physiotherapists or the patient.
Yeah, and when we're attending a short course or a lecture, it's okay to, you know, stand up and say, well, why do you believe that? Or one of the most important questions is, what are the limitations? You know, what else do we need to know before we can advocate the approach that you're talking about? So just be a little bit more critical. I'm a little bit concerned at times that we sometimes we base our arguments on the conclusion from an abstract, from a paper. But when you actually look in a little bit more detail in that paper, there are some significant limitations that mean we can't really do very much with that research. In fact, we should just move on from it. But me and some colleagues we're starting to reinitiate a blog looking at critically appraising shoulder randomized trials, which hopefully will help, you know, be a learning resource as well, but just help to challenge some of these abstract conclusions that seem to dominate certain areas of our world.
Excellent. Well, we look forward to that blog or that new site that you'll be sharing with everybody. That will provide us with some it's always great for everyone else to do the critical reviews and just give us a summary at the end of those. Where else can people find out more about you, Chris?
I've got a homepage at the University of Keele. So if you put my name into Google along with Keele, that will take you there. You can on Twitter at PhysioChris.
Yep.
And again, as I mentioned, I'm not. I think it's fair to say I'm not very tech savvy. So I'm trying to develop this blog in a useful way and give some indications there. But I think probably the best way at the moment is through probably.
Yeah, okay. So we can find you on Twitter to ask you all our questions. Is there anything else before we go that you'd like to share with people today that to help clinicians be a better clinician?
That's a question that you should have asked me before so I could prepare.
Just a final thoughts from all that we've discussed today. Anything that you'd like to reinforce or reiterate? Or
okay. I've got one. I think there's one really important question that everybody should ask through their history. So when you meet the patient the first time, as well as any standard questions that you think you should have, one really important question is, what do you understand is the cause of your problem? What do you think's going on? You know, what have you found out on Google, from your relatives? How are you understanding this problem at the moment? And it always used to disappoint me, the number of people who just said, I've got no clue, but they might have seen X number of clinicians before. So, but what I am mindful of is that group of patients who have these potentially harmful thoughts about cuff tears, bone spurs, etc. And if you pick up on those things, then perhaps the focus of that initial meeting needs to be understanding their perspective and starting to introduce some uncertainty through some of the published research, for example. I think that would be my number one tip, really, just something that's quite simple to introduce and is really enlightening when you can begin to understand how patients think about their problem.
Yeah.
Because often it's different to how we do.
It's interesting because we don't often ask that question particularly, and I think it sounds from all that you've said today that in the shoulder in particular, that's a question that we need to be asking to challenge our own assumptions as well, I think, which is something that we need to do too.
Absolutely.
So, Chris, thanks so much for talking to us today. It's been great to delve into your knowledge. I'm sure we could talk more for hours, and perhaps we will be able to again. So thanks for sharing everything that you have with us today.
Thank you, Rachel. Thanks for the invite.